David, happy spring.
Happy spring. I'm back to you, Todd.
Yeah, we've survived the Ides of March, St. Patrick's Day, and winter. I thought I would start kind of in a strange place. I was working on an editorial for Kidney News and was thinking a lot about the Department of Health and Human Services and just how many different institutes and entities and centers and agencies are part of it. And if you take its kind of annual budget and you think of it as like a country and what the gross national product would be, it comes in the top 10. So it's sort of larger than the total budget's more than Italy as a country and slightly less than France, which is pretty amazing, don't you think?
It is amazing. It's just whenever you just get into HHS, you realize that you need to bring cookie crumbs or breadcrumbs with you because you're going to need a trail to get yourself back out. And I mean that both physically and metaphorically. So it really is truly kind of an elaborate, just big agents, big department.
Yeah, so let me sort of pick up on your metaphor and maybe take it in a slightly different direction, but it's the same concept, which is, at the end of the movie, the book and the movie, The Shining, there's the maze and the sort of navigating the maze. So why don't we pretend that we're in the sort of snowy maze? We can decide which of us is which character at the end of the film. That's probably a separate discussion that would need a psychiatrist. But navigating the Department of Health and Human Services, our first sort of agency will be the Health Resources and Services Administration. So what's the big news from HRSA?
Okay, so HRSA, you've already heard news. Some of our listeners have already heard news out of ASN on this. Which is that a long-time request of ASN and many others in the kidney community has finally been heard and is being acted on. And that has to do with some significant reforms within the organ procurement transplant network, OPTN, which is really kind of critical to running the whole transplant program. It was created by NOTA, and NOTA was passed in 1985. And I got proud of myself from actually being on Capitol Hill the day that it was passed, working. So anyway, it's been a long time coming. There's a lot of things that need to be done, and ASN has really been pushing for at least the last 5 or 6 years, probably more like the last 10. But even more recently, ASN President Michelle Josephson, a transplant nephrologist herself, did meet with the administrator of HRSA. Several of us on staff were in that meeting as well. That's Carol Johnson, the HRSA administrator, to talk about exactly what did get announced here. And also shout out to my colleague, Rachel Meyer here, who's been working on them, and also Dak Cribbs, who's been working on the legislative side, where the Senate Finance Committee has been doing a lot of investigation of OPTN and how HRSA has managed that. So this is a really big, important step. They've outlined kind of a 5-step program that they're going to be undertaking, and we're going to be examining the details of this. And we want to see it being implemented in as robust a fashion as possible. But it does have a lot of things to do with things like the opening up of the contract for bidding for the OPTN contract, and also splitting apart the IT contract portion and letting different entities bid for that. Congress originally had prohibited for-profit entities from bidding for that contract. And I think that's one thing that probably HRSA will be going back and asking Congress to change.
Yeah, so this is, this could take the rest of today's discussion. And I think our thought is we'll go through a couple of other, big picture issues related to the Department of Health and Human Services. And then on a future podcast, we'll do kind of a deeper dive in terms of specifically what's happening here. You did mention the mid 80s, and I do think it's important that, so much of this goes back to the evolution of the federal government. So before the Department of Health and Human Services, there was the Department of Health, Education, and Welfare. And when HEW separated essentially into 3 departments, the HHS piece, I think transplant was kind of was both spread out across several agencies within HHS, but also there wasn't as much clarity. And it sounds like a lot of what's being proposed or a lot of these recommendations from HRSA are trying to address some of that. Do I have that kind of right at a big picture level?
I think historically that's right. I do think that's right. And yeah, I mean, the evolution of HRSA and what happened with HHS is an interesting story. And yeah, but it does go a long way. But there's a lot here that I think as we go into, we're in 2023 now, and this whole structure was conceived of back in the 80s, and it is time for some things to be done a bit differently, and to really bring up to speed the IT portion, the data portion. And I know that sounds kind of simplistic, but I mean, data is just incredibly important in transplant. And if you're really talking about getting people waitlisted, you're trying to see where the organs are available and trying to really manage a system that really needs to be as state of the art as it can be. And like you said, we're going to go into a deeper dive on this with my colleagues and with ASN President Michelle Jefferson in the very near future. But there's some very exciting things in there, and they are really truly trying to improve good governance in the way in which the organization is structured, openness and transparency in bidding for contracts, and real state-of-the-art use of basically data and ways in which to manage data. So that's really an important thing that I think ASN and all of its members can be very proud that this is finally happening.
Yeah, and I think as we move kind of in the maze that we described at the beginning, the metaphorical maze that is the Department of Health and Human Services, it's really important to recognize that there seems to be a fair amount of alignment here between the Biden administration and the House and the Senate. And so last year there were a series of hearings at a Senate level around some of these issues, and they were truly bipartisan. So my sense is that there's going to be a lot of support sort of across the federal government, both the legislative and regulatory branches, to move forward on this. Just before we move to our next issue, I just want to make sure that you agree with that sort of assessment of the landscape.
Oh, I do. I mean, there's a little bit of the essence of, let's go ahead and do this as an agency before it gets done to us. That having said that, we still applaud HRSA for taking the steps, and we are glad to see this all happening. It is just a little bit like you said. It's just there's a lot of different pieces moving around.
So as we turn the corner in the maze and we go to the next piece, the Food and Drug Administration and the Centers for Medicare and Medicaid Services, so FDA and CMS, seems like there's some things happening there related to payment for accelerated approval of drugs.
You were prescient in your introduction here about HHS. This goes exactly to what you're saying. So you HRSA's on one side, then over in CMS you've got really the control of quality and payment for a lot of things, and then FDA, you have the investigation and the decision of safety and efficacy in drugs and devices. And so there's been a lot of movement in FDA to provide accelerated approval for certain, particularly for certain items, and that brings you into a situation where they have done that, and I think most people in the public would think, well, that means that it will become available through Medicare and Medicaid. And that's not always a given, because then CMS says, well, wait a minute, we want to see the data on exactly what we're paying for. And if you had an accelerated approval, and that means you did not complete all of the various trials that under regular approval processes in FDA that have to be done. And it's not that they don't have to be done eventually, but there's not all that data is not available right away. Then CMS is saying, we're not sure we're going to basically pay for all of that straight up. And, this partly has to do with the debate over the recent Alzheimer's drug. And so recently, and I'll try not to make this too complicated. Back in February of this year, CMS said, well, we're going to do 3 payment models, and which is kind of it was kind of a strange approach to this, and that has gotten some people's attention, including 18 Senate Republicans who have basically said, we think you're going to end up gumming up the works for paying for innovative products, and that you're going to be stepping on the toes of FDA, so to speak. FDA, CMMI has come out and basically said, we're not stepping on toes. We're doing our statutory responsibilities. So we're going to see how this plays out. I'm not quite sure exactly where this all ends up going, but the point is that we've been talking about payment for innovation for a long time, as you know.
Yeah, it's interesting because as I think about this issue and I sort of reflect on the relationship between the kidney community and FDA, this is the 10th year of the Kidney Health Initiative. The Kidney Health Initiative is a partnership among the FDA, ASN, and 100 sort of members of the community, including the pharmaceutical industry, the biotech industry, medical device, dialysis industry, but also other health professional groups, the patient population, patient community, et cetera. So there's a lot of constituencies that have worked hard at a pre-competitive level to identify barriers and try to overcome those barriers at moving products through the FDA approval. And there's been huge advances there. But if I'm sort of understanding you correctly, part of the challenge is now, as they go to CMS, it's almost like there's a reprocess, probably using the guise of both quality and reimbursement. And if that isn't aligned better, then you could really see, not just in nephrology, but in other areas, some real challenges. So is that kind of I just want to make sure I have the sort of the macro view of this correct.
Yeah, that's exactly right. And ASN has been really sensitive to the idea that CMS does have its statutory responsibilities to evaluate these items, but at the same time, we basically have been saying to CMS that process needs to be very transparent, and so that any group that might be considering investing in a product that they're going to bring to market understands what they will have to go through to get that payment approved. And that's where some on the drug and device side say that there's not a lot of clarity, so not a lot of transparency. But nonetheless, it is an important space, and we do need to make it a little more aligned, a little more smooth.
So, David, before we move to the third issue, you had mentioned sort of in passing CMMI. Can you just remind us what that is?
Oh, sure. That's for Centers for Medicare and Medicaid Innovation Center. Also, sometimes it's called the Innovation Center at CMS. And that was created under the Affordable Care Act. And so basically what it does is it's given authority to kind of waive certain requirements and spend money to test models to see whether different payment approaches could increase the results, improve outcomes, and or save money. But it's supposed to do at least one or the other or both. And so, it's a really important area. That's where the two kidney models that are currently under use in the United States come from: ETC, the mandatory model, and the KCC, the voluntary model, with its different pathways that includes the contracting entities. So it's a pretty important area, and that's where we will be watching to do different things. But there's another level here we're going to get to in just a second that involves CMS trying to figure out how to make things work.
Yeah, so thanks. Yeah, as we sort of turned a corner, now we're going back sort of a different direction in this maze. And then there's the Office of the National Coordinator for Health Information, or ONC. Then obviously we're going to go back to CMS here, and something around electronic health records, prior authorization, possibly Medicare Advantage. So what's this third sort of set of or pathway in this maze that we need to talk about?
Well, we brought up Capitol Hill and the administration because both of them have been very concerned about certain things. In particular, they've been very concerned about the use of prior authorizations within Medicare Advantage, not just Medicare Advantage, but particularly Medicare Advantage has been of concern to them. And so basically, CMS has been undergoing efforts to try to really kind of improve that and make sure that prior authorizations are used when appropriate, and that they are not really a barrier to a patient getting their care when they need it. And so what that means is the way in which a prior authorization might be, like, you might be denied and then it needs to be appealed. Basically what the Office of the National Coordinator is saying, along with CMS, is this has got to be a very state-of-the-art electronic process. And you've got to be able to state exactly why you did not authorize the treatment, and you've got to do it in a very short amount of time, and it's got to be fire friendly. The different standards that are used for APIs for within what we all call apps, the way that makes it work, so that we can walk around with our phone and open an app, and maybe it's a hospital center, or maybe it's something else, or maybe it's Medicare Advantage, and say, what happened to my request? Why did it get turned down? It got turned down. Why did it get turned down? And then how do I appeal that? And so they're basically saying that's got to be fast. It's got to be modern. It's got to be transparent. And so they are looking at ways to really incentivize making sure that the electronic health records can facilitate electronic prior authorization to really slow this down. And, we've seen a lot of studies recently that really point to prior authorizations as something that are a tremendous burden and drain and burnout factor from people in healthcare field.
So where do you see this going? Because I guess, the first two, just to kind of summarize, is it's pretty clear HRSA's moving forward. They're likely aligned with Congress. There will be changes to the transplant system and things that the community's been advocating for quite some time. On the accelerated sort of payment for accelerated approval for drugs, that too seems pretty clear as to the discussion, sort of what's happening within CMS. This one to me seems a little fuzzier, and I'm just kind of curious if A, you agree with that assessment, and B, if you have any predictions as to how this will move forward.
Well, it could be a little bit fuzzier, but then again, it's really, the proof is in the pudding. That's just all there is to it. If you do this and 2 years later, you're still having skyrocketing prior authorizations, you're having massive delays, then this didn't necessarily improve things, and you have to figure out why. The ONC office takes this stuff pretty seriously, and I think everybody else who's involved in this takes it pretty seriously and wants to see how to make sure this works. The Seema Verma, who was the CMS administrator in the Trump administration, she was pretty serious about making sure the electronic health records spoke the way they should to each other and to apps, and that the information that was contained within them belonged to the patient. And so I think this is an ongoing extension of that. And I think that any group, whether it's an insurer or whether it's a large healthcare entity, any group that decides to do something that makes it more difficult for a patient to get their information is going to come up on the short end of the stick. It's not going to be a good approach. And I think everybody out there knows that they've got to make this work. Patients want it to work, and they want to get access to it. And people also live in an environment where they move around, and they need to be able to take their data with them. So and when an insurer has has your coverage and says no, you can't have something, it needs to be very clear why that you can't have it, and what is the process for going back and readdressing that.
Yeah. And you said this, but just to highlight it, with now more than 50% of Medicare beneficiaries being part of Medicare Advantage programs, this becomes that much more important. So I had started at the beginning sort of referencing March 15th, or the Ides of March. This year on March 15th, the Medicare Payment Advisory Commission, or MedPAC, issued its annual report to Congress. We'll do a deep dive on the MedPAC report in the future, but I just wanted to close, as we're sort of navigating our way out of this maze, and I think we've done it successfully, unlike Jack Torrance. Just really quickly, if you could just let everyone know what MedPAC is, because that's another really important player in all these discussions.
Well, MedPAC is kind of it's an independent group that is basically designed to advise Congress, but it's packed with healthcare officials. It's an independent group. It does have some staffing, and every year it advises Congress in March and again in June. And so it takes a look at big picture issues, big programs, and one of them in particular in this year's report, as normal, was it did look at the ESRD benefit program, which is the dialysis benefit within Medicare. So they kind of take a look and they make comments and make recommendations whether they think current approaches are sustainable or whether they are signaling good progress or whether they're signaling a setback. And so it's a very important thing to work. It doesn't mean that Congress will automatically do everything they do, but it definitely, within Washington, it gets a lot of attention is paid to it.
Great. Well, thank you, David, and thanks for helping us navigate out of the maze that is HHS, and also helping us survive the winter and start the spring.
Yeah, I want to be in spring. I don't want to be left in that maze when freezing to death. Okay.
Yeah, you and me both.
Thank you, Todd.
Great, thanks.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.